Welcome back. This is part 5 of our 6-part explainer series for vestibular physicians, neuro-otologists, and advanced trainees. Today we're tackling a really critical intersection in vestibular medicine, the clinical management of motion sickness susceptibility, or MSS.
This explainer is built directly on the comprehensive literature review, Motion Sickness Susceptibility, a Vestibular Physician's Deep Review of Neural Mechanisms, Clinical Assessment, and Therapeutic Management. That's published by Australian Dizziness Clinics. It's an absolutely fantastic evidence-based resource, and we'll be using its frameworks to guide our discussion today.
All right, let's dive into this with a fundamental clinical reality. There is a massive difference between rewiring the brain and simply masking a symptom. Only active habituation actually rewires the brain's internal models to reduce susceptibility over the long haul. Drugs? Well, they merely mask that sensory conflict. And here's a striking fact we're going to unpack today. Most scopolamine failures in the real world aren't drug failures at all. They're literally just patches applied way too late.
So, good MSS management has to be staged. We're going to cover the baseline non-pharmacological measures, move into habituation, escalate to pharmacotherapy, and finally, look at those tricky edge cases.
Section 1. The baseline. Non-pharmacological measures.
Look, these first-line interventions have to be counseled at the very first patient visit, regardless of whether you plan to write a prescription or not. Our immediate goal here is to reduce the vestibular stimulus amplitude. We need to advise patients to sit in the lowest motion seat, the front seat of a car, midship on a vessel, or right over the wings in an aircraft. We teach them horizon fixation to suppress that visual vestibular conflict, and tell them to keep their head reclined to reduce gravitational otolith loading. And this is a big one. Advise drivers to disclose the journey in advance. Knowing the speed, the route, and the duration actually reduces the unexpected neural conflict through anticipatory central processing. It's a real game changer.
Section 2. The rewiring, habituation, and VRT. Okay, here we transition from passively managing the environment to actively rehabilitating the nervous system, getting right to the root cause. Let's build this clinical ladder step by step. Step 1 was the behavioral changes we just covered. Step 2 is breathing. Step 3 is graded habituation. Step 4 brings in specific vestibular rehabilitation therapy, or VRT. And Step 5 incorporates cognitive behavioral therapy for our anxious, visually dependent phenotypes. This ladder is basically a progression from simple symptom control to profound neurological adaptation. The mechanics of Steps 2 and 3 are highly specific. For breathing, we are targeting diaphragmatic breathing at exactly 6 breaths per minute. Why 6? Because it restores autonomic balance by reducing sympathetic arousal right at the emetic center, and it redirects interoceptive attention. Patients need to practice this for 5 to 10 minutes daily before they even travel. Then comes graded habituation. By using repeated subthreshold exposure, think short car rides or slow optokinetic stripes, we progressively update the brain's internal model. Over a 4 to 8 week period, this literally flattens the symptom curve.
So, how do we know if this active rehab is actually working? What's our benchmark? The target metric for successful VRT and habituation is a sustained 3-point fall in the patient's MSSG short score, alongside their ability to tolerate a 10 to 20-minute optokinetic challenge with nothing more than mild transient nausea. That number, 3, is your clinical green light.
Section 3. The chemical mask. Pharmacotherapist.
Now, we all know habituation takes time, and sometimes patients need immediate relief for a severe, acute exposure. When non-pharmacological measures aren't quite enough, your drug selection should branch based on 3 key questions. What's the exposure duration? Is there a migraine comorbidity? And is the patient 65 years or older? Following this clinical decision tree prevents the kind of generic, one-size-fits-all prescribing that so often leads to treatment failure or really unwanted side effects.
Let's break down the heavy hitters. Scopolamine, our anticholinergic, is highly effective for long exposures, up to 72 hours. Then we have our first-generation H1 antihistamines. Cinnarizine and dimenhydrinate are your everyday workhorses, though they do cause some sedation. Promethazine has the absolute highest antiemetic efficacy, but it is deeply sedating. A massive caveat here, folks. Promethazine is strictly barred for patients with operator duties. No driving, no flying, period. Finally, for those tricky vestibular migraine patients with refractory nausea, we might add a D2 antagonist like prochlorperazine as an adjunct to target the area postrema directly.
And this brings us right back to our hook. The single most common scopolamine prescribing error in clinical practice is timing. It must be applied 4 hours before exposure.
Patches applied reactively, after the patient is already feeling sick, are totally ineffective. Actually, scratch that. It's worse than ineffective. They saddle the patient with the full anticholinergic burden, like dry mouth and blurred vision, without giving them any of the therapeutic benefit. Always, always counsel your patients 4 hours early.
Section 4. Edge cases. Special prescribing.
Vestibular medicine is rarely straightforward, right? We frequently have to tailor prescriptions for specific populations. Take first trimester pregnancy. These patients have a dramatically amplified susceptibility due to hormonal sensitization. Scopolamine and promethazine are category C and generally avoided. Instead, we lean on ginger extract at 1 to 2 grams or dimenhydrinate. On the flip side, we have our elderly patients, age 65 and up. Paradoxically, their baseline susceptibility is actually lower, but if they do need medication, we must avoid scopolamine and diphenhydramine due to the Beers criteria. The central anticholinergic cognitive burden is just way too high risk. For them, cinnarizine or cyclizine are definitely the safer preferred choices.
Section 5. Summary and next steps.
If you take away nothing else from this explainer today, remember these 2 clinical pearls. First, prioritize behavioral measures and graded habituation, because they are literally the only tools we have that offer lasting neural rewiring. And second, when you do reach for the prescription pad, remember that scopolamine works brilliantly, but only if applied early. Tailor your antihistamines, your D2 adjuncts, and your edge case medications precisely to the context of the patient sitting in front of you.
I want to leave you with a bit of a provocative thought. As the screen era rapidly advances, how are we going to treat an entire generation experiencing profound motion sickness without ever physically moving? The classical rules of motion sickness are shifting right beneath our feet. And that exact question cues up part 6 of our series, where we'll turn to cybersickness, visually induced motion sickness, and the absolute frontier of vestibular research. You really won't want to miss it.
This has been an explainer based on an Australian Dizziness Clinics Vestibular Physician Review. For the full deep dive literature review, all the complete decision trees, and the clinician cheat sheet, be sure to head over to AustralianDizzinessClinics.com. Thanks so much for joining me on this deep dive, and I'll see you in part 6.